Hello, I am Dr. Paninish Chandra Runnu. I am working here in Ranchi in KC Rai Memorial Hospital as a consultant physician and cardiologist. I am here now to talk about the hypertension. As per WHO, nearly 63% of total deaths in India are due to non-communicable diseases, of which 27% are attributed to CVD, which affects 45% people in the 40 to 69 age group. Raised blood pressure is among the most important risk factors for cardiovascular death. Moreover, it remains poorly controlled due to low awareness about hypertension, lack of appropriate care through primary care, and poor follow up. In India, the prevalence has gone up over 30 years to 38% in men and 32% in women, from 29% and 28% respectively. Despite that, nearly half of the people and for 51% of men and 41% of women with hypertension were unaware of the condition. Additionally, over 62% of the men and more than 53% of the women living with hypertension did not get treatment. Medication was used to control blood pressure in fewer than 1 in 5 men and 1 in 4 men, women with hypertension worldwide. International Society of Hypertension has released the ISH 2020 Global Hypertension Practice Guidelines. The inclusion of optimal and essential treatment paradigm attempts to address the issue, that is resource poor settings. Optimal care refers to evidence-based standard of care, and whereas essential standards refers to minimum standard of care to allow specification of essential standards of care for low resource settings. The American Heart Association and ACC has released a scientific statement in 2021 offering new guidance for management of stage 1 hypertension among patients with low atherosclerotic cardiovascular disease risk. Among low risk adults, that is, no ASCVD or 10 years CVD risk less than 10%, with stage 1 hypertension, that is blood pressure 130 to 139 mmHg systolic and 80 to 89 mm of diastolic. Management starts with non-pharmacological therapy. If blood pressure remains uncontrolled at 3 to 6 months, consider starting pharmacological therapy. Acute respiratory distress syndrome, that is ARDS, is potentially fatal condition involving lung damage, and experts often associate with severe COVID-19. A recent study which appears in the Journal of the American College of Cardiology reports that metoprolol can reduce lung inflammation and improve respiratory function in the people with COVID-19 induced ARDS. And lowering systolic blood pressure targets down to the 110 to less than 130 mmHg range substantially reduces severe adverse events in the STEP randomized trial, affirming the sprint finding for an older Chinese population. Among some 8,500 patients aged 60 to 80 in China, the intensive target trimmed 26% of the composite CV race, finding from now a second major trial supporting a lower target could unite the guidelines, which even among the US professional societies range from threshold of 130 to 150 mm of Hg. With regard to prognostic value of ambulatory blood pressure monitoring and nighttime blood pressure, the 2018 European Guidelines on the Management of Arterial Hypertension recommend that the diagnosis of hypertension should not only be dependent on office BP management, but also on out of office measurement such as ambulatory blood pressure monitoring or home blood pressure monitoring. 24-hour and nighttime BP measurements were associated with greater risk of mortality and a composite of CV outcome. Thus, they may be considered as the most relevant measurements for estimating CV risk. For every 20 by 10 mmHg increment of BP measured at night, the risk of mortality increased by 23% and the risk of cardiovascular events by 36%. Most patients with hypertension requires lifelong medical therapy to achieve optimal BP control. The 2018 European guidelines equally recommended five classes of hypertensive drugs. Considering high non-adherence treatment, the importance of combination treatment is particularly highlighted to improve adherence to therapy and BP control. Therefore, the 2018 European guidelines recommend, especially in the context of lower BP target, to start antihypertensive therapy with an initial dual fixed dose combination of ACE inhibitor or ARB plus CCB or diuretics. Since early July 2018, products containing valsartan have been recalled worldwide. The reason is the detection of known carcinogen, namely N-nitrosodimethylamine, which can be found in cannonsartan, irbesartan, losartan, olmesartan, and valsartan. NDMA has been classified by the WHO International Agency for Research on Cancer to be carcinogenic in humans. If 1 lakh patients would have received NDMA contaminated valsartan from Jianghuai manufacturing site where the highest level of contaminants were found every day for 6 years in the highest dose, it could result in 22 additional liver cancers over the lifetime of these patients. The presence of NDMA in these drugs could lead to 8 additional cancer cases in 1 lakh patients if they had taken the highest daily dose over 4 years. Valsartan recall accompanied by a significant increase in the rate of emergency department visits of plus 6%. The HYGEA study represents the largest study that tested nighttime antihypertensive treatment. In this trial, chronotherapy was associated with a significant reduction in endpoints, including death. The HYGEA chronotherapy trial tested whether nighttime therapy is in comparison to usual upon awakening hypertension therapy exerts a favorable CV risk reduction. The largest study induced a total of 19,084 hypertensive patients. During an average follow-up of 6.3 years, 1,752 participants experienced the primary CV outcome. An ambulatory BP measurement was performed for 48 hours to collect data on how BP differed during sleep. The RR reduction for CV events was significantly improved for nighttime treatment and when compared with awakening treatment. So these are the things on gist of this hypertension and management and some points regarding COVID-19 pandemic. And thank you for the patience hearing. Thank you.